Actually, the topic is UKR or unicondylar knee replacements. Why should we be considering robotics? Why robotic? So let's start off. So we all know that partial or unicondylar knee replacements are underutilized. I don't know how much of us would agree to it, but we know that in literature indicates that around 47% of knee osteoarthritis patients may be eligible for a unicondylar knee replacement. Even if we were not to believe that it is 47%, the Oxford group says about 25%. So about 20 to 40% of patients who undergo a total knee arthroplasty may actually be candidates for a unicondylar knee replacement. So the big question is, why are they underutilized, despite knowing that they have a lower infection rate, less blood loss, decreased length of hospital stay, lower perioperative morbidity, quicker recovery, better range of motion, more natural knee kinematics, and higher patient satisfaction. Yet, they remain underutilized. Why? So I think when we come to this why, there are two important considerations. One is the fact that unicondylar knee replacement is actually a technically demanding surgery. It does have a longer learning curve, and most surgeons perform low volume surgeries, and therefore the surgeon errors tend to creep up, and that's why most surgeons are little skeptical about using a unicondylar knee replacement. The next concern is predominantly the concern of lower survivorship when they compare it to a total knee arthroplasty, and this is predominantly based on the registry data that shows significantly higher revision rates for unicondylar knee replacements. So technically demanding surgery it is, yes, but why? Because we are not able to consistently achieve our alignment goals, our implant positional goals, or our soft tissue balancing and tracking goals. So when we look at our x-rays, when we do them in a conventional manner, we are often not very satisfied once we do a unicondylar knee replacement. And that's it. That is why most surgeons sort of do a few of those unicondylar knee replacements and then they stop again and move back to doing total knee arthroplasties for patients who require a partial knee replacement. And there could be anything under the sun that you could be worried about. So overcorrection, undercorrection, over-resection, subsidence, overhang, excessive slope, malrotation, ACL injury, and the list goes on. So what is important is that unicompartmental knee replacement or unicondylar knee replacement is an unforgiving surgery. Most common causes of early failure of UKR are actually surgeon errors. And surgeon errors are fully in the surgeon's control, and that makes it scary for the surgeon to use a unicondylar knee replacement surgery. In a study by Kaziran et al., when he looked at high prevalence of radiographic outliers and revisions with unicompartmental knee arthroplasty, he found alignment and overhang as two significant factors accounting for revisions. And if you look at it, he looked at the coronal femur and tibia and the sagittal plane, the femur and the tibia, and as you can see, for outliers, the revision risk was 15.4, 17.9, 16.2, 15.2%, which is relatively significantly high. For overhang, 38.2% for medial overhang, and for posterior overhang of more than 2 millimeters, about 25%. So reasonably high risk. What is important is the rate of failure among knees that had no alignment or overhang outliers was 0%, which means that if we could avoid overhang and if we could place our components within the reasonable alignment limits, we may have no failure rates. So it is a reliable surgery, technically demanding but achievable. The most common modes of failure that we found were malalignment or instability, mechanical failure, and osteoarthritis progression due to overstuffing of the lateral compartment. Again, all three parameters which were in the surgeon's control. Unexplained pain was only 8%. For lack of time, I won't go into much detail, but in essence, this brings us all down to if the errors are more in the surgeon's control, That is why robotic assistance can actually help us out and help us be more accurate with our alignment. Now, before I go on to that, just another point, the concerns of lower survivorship relative to total knee arthroplasty. So earlier studies very clearly showed very, very high failure rates. However, more recent studies, the cumulative revision rate at 10 years for UK's for unicompartmental arthroplasties in the 2023 American Joint Replacement Registry was only 3%, so which is not too high. It's still high. It's still about 20% higher than total knee arthroplasties. And a recent multi-center randomized controlled trial comparing UKs to TKs showed a similar revision rate at 5 years. So we are getting better with unicondylar knee arthroplasties. Concerns of why revision rates of UKR in national registries are much higher than in many cohort studies and randomized controlled trials still remains something to be understood better. A lot of people believe that compared with TK, more UK patients with poor outcomes are more likely to undergo revision for unknown reasons or unexplained pain. So if a patient comes to me with unexplained pain and has a unicondylar knee replacement, I'm more likely to revise him to a total knee arthroplasty. While if a patient with total knee arthroplasty comes to me with unexplained pain, I might ask him to continue with the same joint and see how it goes. So we have a lower threshold of revising a unicondylar knee arthroplasty compared to a total knee replacement. So coming back to the main point, robotic assistance allows us improved accuracy and precision, reduces surgeon errors, and therefore can help improve survival rates of unicompartmental knee arthroplasty, and therefore is a very good tool to be used. Literature to date largely suggests that robot-assisted UKs more accurately achieve limb alignment goals, proper implant positioning and restoration of joint line, and significantly reduces outliers. Does this necessarily extrapolate to improved outcomes and reduced revision rates? We have still literature that may be on both sides. However, there is no doubt that the trend is increasing, and we believe that over 37% of UKs will be performed robotically within the next decade. We are now at about 15–20%. And why should we not? Considering that we can accurately assess where we are positioning our tibial component, we can accurately save our ACL, we can accurately size our tibia, we can make sure there is no overhang, we can match our tibial slope, we can put our femoral component exactly where we want to, both in the coronal and the sagittal plane, and we can lateralize it with a very high degree of accuracy. We can match our gaps, and we can also look at femoral and tibial tracking. So all of this, and have every time consistently a good looking X-ray. So if robotics is giving us all this, it does lead to significant increase in the utilization of unicondylar knee replacements. So robotics, in my opinion, is a significantly important tool in increasing the confidence and the volume and the success rates of partial knee replacements. Thank you.